This Level 1 study used a randomized controlled trial with a convergent mixed methods design to evaluate the impact of VR simulation on basic life support training. A total of 59 fifth-term nursing students were randomized into two groups, one receiving VR-enhanced BLS training and the other receiving standard BLS training alone. Quantitative data were collected through questionnaires, while qualitative insights came from interviews and observations. These data were analyzed separately and later integrated to capture a more complete understanding of the intervention's impact. Results showed that the VR group demonstrated greater self-reported self-efficacy and professional competence. Interview analysis revealed three major themes: altered perception of time, improved awareness of clinical competencies, and more frequent use of professional language. Overall, VR-enhanced training had a positive effect on students' confidence and preparedness, especially in BLS scenarios. This study is a randomized controlled trial that used a simulation-based experimental design to evaluate emergency professionals' adherence to the maternal cardiac arrest algorithm. A total of 250 participants were randomly assigned into 50 groups and took part in pre- and post-training simulation scenarios. High-fidelity simulation was used to assess and enhance clinical performance. After an initial scenario and structured pre-briefing, participants received targeted debriefing focused on the algorithm. 1 week later, they were reassessed in a second simulation to measure improvement. Quantitative data, including performance scores, were collected and analyzed using statistical methods like t-tests. The results demonstrated measurable improvements in adherence to the maternal cardiac arrest protocol, showing the effectiveness of simulation-based training in enhancing emergency response performance. Today, I'm presenting a Level 1 study, specifically, a randomized controlled trial using a crossover design. In this quantitative study, each student served as their own control, experiencing both low-fidelity and high-fidelity simulations. Medical knowledge acquisition was measured using pre- and post-test multiple-choice exams. The methods involved comparing post-test score differences between simulation types, using 95% confidence intervals to assess statistical equivalence. The overall CI ranged from -0.22 to 0.68, indicating no significant difference in knowledge gains between modalities. Subgroup analysis for specific topics also supported non-inferiority. Finally, both groups showed similar improvements from pre- to post-test, with a CI of -0.14 to 0.96. In summary, this study demonstrates that low-fidelity simulation may be just as effective as high-fidelity in terms of objective knowledge outcomes. Based on the three studies, there's no single best simulation method. Each serves a different purpose. Low-fidelity simulation is just as effective as high-fidelity for knowledge acquisition. High-fidelity simulation improves clinical skills and protocol adherence, especially in emergencies. VR simulation enhances self-efficacy, communication, and professional confidence. Ultimately, the best approach depends on the learning goal, and combining methods may offer the most comprehensive training. VR-enhanced simulation significantly boosted self-efficacy, professional language use, and awareness among nursing students during BLS training, showing clear value in building confidence and professional behaviors. Whether it's knowledge, skill application, or confidence, a blended approach may ultimately provide the most well-rounded educational experience.
This Level 1 randomized controlled trial examined the effects of different teaching methods on nursing students' anxiety, self-confidence, and auscultation skills. Students were randomly assigned to one of three groups: simulated patient, high-fidelity simulator, or traditional education. Researchers used two validated tools, the Nursing Anxiety and Self-Confidence with Clinical Decision-Making (NASCCDM) scale and the Auscultation Control List. Data were collected through pre-tests, post-tests, and a 15-week follow-up. The results were clear. Both the high-fidelity simulator and simulated patient groups showed increased self-confidence and decreased anxiety, effects that were sustained over time. In contrast, the traditional group saw only temporary improvements, with confidence dropping and anxiety rising by the 15-week follow-up. When it came to psychomotor skills, all groups improved, but the high-fidelity simulator group scored significantly higher than the others. This Level 1 randomized controlled trial compared the effects of multi-patient simulation versus single high-fidelity simulation on nursing student competence and simulation effectiveness. Participants completed 2 simulation sessions, spaced 30 days apart, with data collected before the first and after the second session. The study used 3 validated tools: the Creighton Competency Evaluation Instrument, CCI, the Clinical Competence Questionnaire, CCQ, and the Simulation Effectiveness Tool, modified, SETM. While both groups were similar in background characteristics, the intervention group, those in multi-patient simulations, showed greater increases in clinical competence scores. Qualitative results highlighted the value of structured simulation. 73% of students reported that pre-briefing improved their learning, 71% strongly agreed they had meaningful opportunities to practice, 85% felt more confident in handoff communication, and 70% found debriefing to be valuable. This study is a Level 1 multi-center randomized controlled trial conducted across 5 universities. Nursing students were randomly assigned to one of 4 groups: high-fidelity simulation, computer-based simulation, a combination of both, or a case study group. Researchers assessed outcomes using several validated tools, including the Creighton Competency Evaluation Instrument, AITCS2 for teamwork, Yoon's Critical Thinking Scale, and the Caring Dimensions Inventory. Data were collected through online surveys at baseline, post-intervention, and 3 months later, with hands-on skills assessed in person. All groups showed improved knowledge after the intervention, but the high-fidelity simulation group had the greatest immediate gains. At the 3-month follow-up, knowledge declined in the computer-based and case study groups, while the high-fidelity and combined simulation groups retained or even improved their knowledge, especially the combined group, which had the best long-term retention, though differences weren't statistically significant. For interprofessional collaboration, all groups improved except the high-fidelity group. Surprisingly, the case study group showed the greatest improvement in teamwork and collaboration. When it came to clinical skills, all groups improved both immediately and at 3 months. The combined simulation group showed the most immediate skill improvement, while the high-fidelity group had the most sustained skill development over time. However, no significant differences in skills were found among the groups at follow-up. Across all 3 studies, we see strong Level 1 evidence from randomized controlled trials supporting the use of high-fidelity simulation in nursing education. Each study demonstrated consistent improvements in students' confidence, reduced anxiety, enhanced psychomotor and clinical skills, strengthened critical thinking, and even better interprofessional collaboration. The research included sample sizes ranging from 60 to 239 students and was conducted in diverse university simulation labs, ensuring broad applicability. Importantly, all 3 studies used validated tools to measure outcomes, such as the NASCCDM for anxiety and confidence, the Creighton Competency Evaluation Instrument for clinical performance, and other established scales for critical thinking, collaboration, and caring. Overall, according to the Johns Hopkins Nursing Evidence-Based Practice Tool, this body of evidence is rated as Level 1, Quality A, meaning it is high quality and highly reliable for guiding practice changes.
This article presents a Level 1 randomized controlled trial examining whether structured observational tools improve learning of non-technical skills, such as situation awareness, among anesthesia residents. The study used the Anesthetist Non-Technical Skills, ANTS tool, a validated framework that evaluates task management, teamwork, situation awareness, and decision-making. The intervention was grounded in strong theoretical frameworks like Kolb's experiential learning and Bandura's social learning theory. Although the study found no significant difference in overall NTS scores, the observer tool group showed improvement in decision-making. Limitations include the single-site design and use of one evaluator. These findings suggest that observer tools may help with specific aspects of non-technical performance, though overall effectiveness may vary. This article introduced an avatar-based patient monitoring system during simulated anesthesia emergencies. The study's strength lies in its rigorous randomized design and use of Cox regression, a statistical method used to compare the timing of events between groups. Participants using the avatar system more accurately identified the cause of the emergency. Although the study did not outline a specific learning theory and was conducted in a simulation setting, It still supports avatar-based tools as promising methods to improve situational awareness during critical events. This study focused on long-term learning retention after neonatal resuscitation training, using both high-fidelity and screen-based simulation. Both groups showed improvement in non-technical skills over time, but there was no significant difference between the two methods. The findings challenged the assumption that high-fidelity simulation is always better. Although the sample size was small, the results suggest that screen-based simulation may be just as effective, especially in settings with limited resources. All three Level 1 RCTs showed that simulation, whether avatar-based, high-fidelity, or screen-based, improves non-technical skills like situational awareness, decision-making, and communication. Tools like ANTS validated these outcomes. While no single method proved superior, blended approaches offer broad benefits. Most studies lacked consistent educational frameworks like Kolb or Bandura, which should be addressed. Clinically, blended simulation is feasible. Many programs have labs or can use screen-based tools. Observer tools help retention, especially in crises. As Deerholt and Dang note, strong evidence plus practical feasibility supports implementing this change.
Yes, adopting high-fidelity simulation would significantly improve clinical outcomes. When simulation is matched to specific learning goals, it ensures that training directly addresses real clinical challenges. Using a blended simulation approach, combining high-fidelity, computer-based, and case-based methods reinforces learning through multiple modalities. Structured pre-briefing and debriefing are essential. Pre-briefing prepares learners with context and expectations, while debriefing reinforces clinical reasoning and reflective practice. Using validated evaluation tools ensures consistent measurement of growth in areas like confidence, competence, and decision-making. Finally, implementing simulation early and consistently in nursing education builds strong clinical habits and improves readiness from the start, leading to better patient care, fewer errors, and stronger overall clinical outcomes. Yes, implementing high-fidelity simulation would improve satisfaction for both nurses and patients. For nurses, it builds confidence and reduces anxiety, especially when facing complex or high-stakes situations. This increased competence leads to greater job satisfaction, and simulation also strengthens communication and teamwork skills, creating a more supportive and effective work environment. For patients, the impact is just as important. Simulation-trained nurses provide safer, higher-quality care with fewer errors and delays. Patients also benefit from improved communication and professionalism, which enhances trust and satisfaction with their care experience. In short, high-fidelity simulation not only prepares nurses to perform at their best, it leads to better outcomes and more positive experiences for everyone involved. High-fidelity simulation helps reduce healthcare costs for patients by training providers to deliver safer, more efficient care. First, it leads to a significant decrease in medical errors by giving students hands-on practice in realistic, high-pressure situations. It also enhances emergency recognition and teaches providers how to respond quickly and appropriately, often preventing costly complications. Because simulation builds clinical confidence and communication skills, patients benefit from clearer instructions, fewer misunderstandings, and better coordinated care. It also helps prevent delayed or missed diagnoses, which can lead to serious and expensive health issues if not caught early. Faster, more accurate interventions reduce the need for unnecessary tests or extended hospital stays, and ultimately, the chance of readmission. In short, high-fidelity simulation creates well-trained providers who help deliver safer, smarter care, and that means lower healthcare costs for patients. Yes, implementing high-fidelity simulation would greatly improve unit operations. First, it increases staff preparedness by allowing team members to practice and refine clinical and decision-making skills in a safe, controlled environment. It also strengthens interprofessional teamwork and communication, especially during high-stress or crisis situations, leading to more coordinated, efficient care. Simulation reinforces standard protocols and clarifies team roles during emergencies, which reduces confusion and improves response times. It also encourages a culture of continuous learning through regular debriefings, where teams can reflect and improve after simulated events. Best of all, it's a feasible intervention. Most hospitals can implement it using existing simulation labs or structured staff training programs.